Well, welcome, doctors. Thanks for joining us in the fourth of our four-part series on breast cancer. We talked about prevention, we talked about diagnosis, and we've talked about treatment. I want to shift gears a little bit and talk about advocacy and awareness. We go to a lot of walks. Almost every weekend in the spring and in the fall is walk season, and we're at these events, we're talking to patients. But I'm overwhelmed by the number that turn out for the breast cancer walk. We go to kidney cancer, we go to other things, and there's people. But when it comes to breast cancer, the awareness that is out there, the money that is being raised, the money behind it. Are we closer to finding a cure here? Is the research, are we going in the right direction? With sheer numbers, I have to believe that we're getting close.
Believe whatever you'd like. The data do not support that. One of the criticisms of the war on cancer and the billions of dollars that have been spent on it is that we've not gotten very far with regard to our hope to cure it. We've gotten a little bit. So let's just look at breast cancer, very simple arithmetic here. We have improved overall survival by and large for early stage breast cancer. We haven't touched stage 4. Stage 4 is stalled out. But for early stage breast cancer, which may or may not relate to overdiagnosis, finding it, we have moved the ball 26% downfield. Good, it's not nothing. And if you have breast cancer and you're one of the women who's had and enjoyed an increased 26% increased survival, that's not nothing. The overall incidence of breast cancer during the same period of time that we've moved the ball downfield 26 yards, shall we say, the overall incidence, numbers of breast cancer has increased 300%. So, 300% more women with breast cancer, and you've moved the ball 26% in terms of their survival. This is not victory, this is not close to victory, but if you understand what cancer is once it gets going, how heterogeneous it is, how diversified, how adaptable and flexible it is, it's way far down the road ahead of you by the time you find it, by the time you treat it, by the time it escapes your treatment. I think that it's exceedingly difficult. I'm not going to say no, because that would be arrogant and probably ignorant. But I think it's exceedingly difficult to imagine that we're going to find a cure, and that this is not a function of putting more money into the proposition. It's not a money problem. If we spent as much money trying to cure polio as we have spent trying to cure cancer, how far down the road would we be curing polio? We have a vaccine that prevents polio. Cervical cancer, how far down the road would we be in curing cervical cancer? We have a vaccine that prevents cervical cancer, and liver cancer with the hepatitis vaccine. So what I'd like to say is, I applaud the nobility and I applaud the enthusiasm and the generosity of spending a lot of money, but if you can prevent a cancer, if you can prevent breast cancer, that's what you should be doing.
So it leads me to ask, with those kinds of numbers, the increase in breast cancer, 300%, I think you said, are we trying to cure the wrong thing? Are we, when I think about those numbers just in order of magnitude, what are these? I mean, we touched on some of them in, talking about diet and talking about other things. Are there other environmental factors that are leading us to this big 300% number that's glaring us?
Absolutely. We've got an environment that's increasingly toxic, more toxic by the minute. We've got genetic predispositions that we know. You mentioned in, I believe it was the second episode here in the series, where you talked about colon cancer screening, and that if you had a family relative that you were invited to begin your screening 10 years earlier. Those data were actually generated at Memorial Sloan Kettering by the cancer colon department because what they found was that over a period of time in the next generation, the genetic fragility and defects that occurred in grandma tended to occur 10 years earlier in the next generation and 10 years earlier in the next. This may explain what Sophie was talking about when she said, when I first got into this, women were in their 60s, and then they were in their 40s, and now they're in their 20s. Every generation 10 years earlier. So we've got a wildly toxic environment. We've got genes going more and more berserk. We've got a virus that's out there, scourge of the world. This explains, I think, the 300% rise in the incidence of breast cancer. I think that explains it. And as I say, let's go back to my favorite metaphor, which is, 9/11, the plane going into the building. Once you get the cancer, okay, how are you going to cure all of that dust and debris and melted metal and broken glass and dead people? How are you going to cure that? Okay? It's really hard. You can build another one. You can't get that one back. It's down. It's gone. And I don't want to sound, terrible doomsday, because we have made progress. But having cancer is very much like having a plane go into the building and the building come down. Like, you can prop it up, but there's dust here and there's debris there and so on and so forth. And it's very hard to catch up, particularly because it's not just as if there's a melted girder down there on the ground. These cancer cells adapt. They're like, you're going to give me adriamycin? Fine, I'm going to become resistant. You're going to give me Taxotere? No problem. You're going to give me Xeloda? No problem. Because all I need is maybe 10 or 11 of these billions of cancer cells that have developed a resistance, and I can wait you out, because cancer cells live forever. They are immortal. You're going to die, I'm going to die, we're all programmed to die. Cancer cells did not read that memo. Cancer cells have within their programming immortality. Okay? They can multiply and divide, they can outlive you. So this is why we see that women who are treated very early and they've got good results early on, after 30 years they're still getting recurrences of breast cancer. Those cancer cells are outliving them.
So, Dave was talking about in the month of October, the whole city turns pink. Everyone's very engaged in breast cancer awareness during October. But October comes and goes and people become unengaged. And something we were talking about when we were discussing doing this series was that potentially breast cancer awareness is a little bit overplayed. People are becoming disengaged. People aren't doing the things that can save their lives. Self-exams, for example. I talk to the women who are close to me who know that I've gone through this and say, are you doing a self-exam? I'm like, no, I don't really think about it, So what can we do to continue this engagement throughout the year when it's not the month of Pinktober?
Well, I think we're doing one of the things now is talking about it, and talking about it in the context of what's new also. I think when the conversation changes, it piques people's interest again. There's more to talk about when you start talking about diet and you start talking about new technologies and you start talking about prevention instead of treatment and the virus that people have not heard about. So bringing in what's new is a great opportunity to have people start getting engaged again. I think what's very interesting about breast cancer in particular is just the sheer numbers of people affected is probably why you see that difference in terms of other cancers. There's just so many more people affected. Everybody in the world knows someone who's had breast cancer. Everyone. And most people, it's someone who is close to them in some capacity. So on the one hand, it touches everyone in a way that few diseases do, just from the sheer numbers. But on the flip side, there's so much overexposure that we can get a little numbed. So I think the trick is tap into the fact that everyone can relate and tap into it by bringing in some new information that makes them pay attention again.
Right.
So you hit on something. You said not everybody knows about the virus, right? And this book, The End of Breast Cancer, The End of Breast Cancer, a Virus and the Hope for a Vaccine. Why aren't we talking about this?
Well, we are, because here's an important piece of information. The former president of the American Society for Clinical Oncology, who was also the former president of the American Association for Cancer Research, is the lead investigator. This man. This man is Holland, James Holland, at Mount Sinai, who has led these august institutions, has been a pioneer, was a fellow at the National Cancer Institute, testified before Congress in the summer of 1970, in the run-up to the War on Cancer and the National Cancer Act, and said, the virus, the breast cancer virus, he's been talking about it. On the 60th anniversary of the National Institute of Health's clinical center. The NIH's clinical center is the largest cancer research center in the world. They've been around for 60 years. They were having a 60th celebration. You can imagine the fanfare. And who did they invite to give the keynote address? James Holland, who had been a fellow there. Walked in to the clinical center on the day of its opening as a cancer fellow, and has led the charge through leukemia and lymphoma, made his reputation, brilliant man, and then moved over to the breast cancer virus, and has been there with this human breast cancer virus for the past 30 years. And when the NIH said, come on, we're going to have a party, and we're going to give you a whole day of discussions, it was Holland who led the discussion that day with 30 years of research on the breast cancer virus. Very humble man, but you stop talking when he's in the room. He's that important. So, yes, it's being discussed. Yes, the National Institutes of Health would not have invited him if they did not endorse this work. The question is, mind the gap. Where is the gap? Where is the gap between, we've got a leader, a thought leader, highly respected, who's an advocate for this, and for good reason, and yet we don't have traction in this profit-driven war on cancer? What is the missing piece here? What is the missing piece? And how can we, as advocates, what are we going to do to get across what appears to be a pretty large gap?
Yeah.
It's interesting to me that there's, of course, not a lot of play in the media around the virus and Dr. Holland, who you've mentioned. Mm-hmm. And in the last couple years, we've had so much press about cancer, especially when Vice President Joe Biden announced his cancer moonshot. It's surprising to me that this did not take up with the moonshot, because, this certainly seems like we could, at 2020, potentially reach the end of breast cancer if the virus had been taken up with the moonshot. So what are your thoughts around the moonshot, and do you think we're on the right track with that?
The National Institutes of Health, if you've got a moonshot for cancer, what you have there are people who are politically involved with the profit-driven healthcare system. So let's look at that system very quickly. There are 3 minimum specifications for our profit-driven healthcare system. They are, number 1, find everybody who's sick. Okay, that's screening. If you're sick, we're going to find you. Treat them to the best of our ability, even if we're not able to do that so cost effectively, even if what we give you does not extend your life measurably. Treat them as much as possible, make a profit. That's the profit-driven system. So the first 2 components, minimum specifications, are noble, they're good, that's why we went into this profession. Find the sick people and treat them. The profit-driven system is what runs, it's driving the bus. Mm-hmm. So if you're going to make $1 billion on a vaccine, you're only going to do that if you don't have a disease that you can make a lot of money on. So there's no race, there's no month. What's the color for cervical cancer? I don't mean to trivialize it. I'm just saying, that's how you get a cervical vaccine. Mm-hmm. Are you going to get a breast cancer vaccine? I think, again, without, at the risk of sounding, hysterical and peripheral, I do think that the financial assessment and the decisions that are made impact the decisions that are made to fund this vaccine or not, which is why I am not surprised that the Israelis and the Italians are way down the road because they don't have a profit-driven healthcare system. They don't need breast cancer, they don't want it, and they'll be very happy to have a vaccine.
So, like, what's the tipping point? You know, we've discussed other medical innovations that we've had, cures for other things, HPV vaccine, polio vaccines. We were able to establish a tipping point there where it was maybe more beneficial to vaccinate people. Can we establish one with breast cancer as well?
I think it's happening offshore. I think, you know, there have been a lot of wonderful good things that have happened based on our profit-driven healthcare system. I'm not opposed to capitalism. I think it's been distorted. I think that the profit-driven healthcare system certainly has distorted our ability to diagnose and treat and take care of everyone optimally. I think the tipping point is going to come offshore. I do. I see it happening. And I regret it because the virus was discovered here, all the groundwork was done. Holland has been doing it, okay? But I see a petrified forest here. So I think the tipping point may come, as it did for the polio vaccine, because Sabin, who created the second, more effective, less harmful polio vaccine, was run out of the country. I don't know if you know the story. He was run out of the country. No, we don't need that. We've got this one. It's fine, blah, blah, blah. He was like, no, mine is really better, okay? He gets on the boat to go to Russia, because Russia, he's a Jew, okay? He, you know, his family barely gets out of Europe ahead of Hitler. He goes to Russia. They've killed, I don't know how many Jews in Russia, in the 1950s. He gets run out of the United States. He goes to Russia with a polio vaccine. He's on the boat. And who's on the boat with him but John Bittner, the guy who discovered the breast cancer virus. And they spent the whole Atlantic voyage talking about the problems that they were having getting this information onto center stage. So Sabin goes to Russia, and he inoculates 10 million Russians, and he proves that his vaccine is better. And the Russians then sell it to the Japanese, and they're happy to have it. And then Sabin comes home a hero. Oh, all along, we knew.
Of course.
So I think, I don't know, Sophie, I'd be very interested to know what you have to think about this, but I'm thinking it's going to happen elsewhere, and it's a shame because I'd like for it to happen here.
I think it's looking like it's going to happen elsewhere. I think that we are trying to figure out how we can make it happen here. But I think the other part of it, lesser but maybe relevant, is, you know, I always think in plastic surgery it's very funny, especially with technology. You know, the technology is marketed to the patients, not the surgeons. The same way that you market the, you know, kids' cereal to the kids, not the mom. And if the kids scream enough, the mom buys the cereal. And if the patients call enough, the doctor buys the machine. And maybe part of what we can try and do also is just get the word out. And maybe if enough awareness is there that this is something that even exists, it might push the right button in the right place. I mean, you don't need a lot of people or a lot of resources. You just need a couple of the right ones. And I think that's what we're trying to achieve today.
Right.
Well, if the train is coming down the track and it's going to get there eventually anywhere, regardless of where it comes from, right?
Yeah.
I have to think that sharp minds are looking at this and saying, okay, well, what does this mean for me and how can I get on board?
Or get in the way.
Well, the train will run you over.
Get in the way as long as you can. And again, you know, at the risk of sounding, you know, like someone who's hanging from one hinge, look what the tobacco industry did. Look what the fossil fuel industry did. And they did not have the advantage that they were helping people. No one said that, you know, tobacco.
Right.
They tried to say tobacco was good for you.
Well, they did, actually.
Lasker in the 40s
Fantastic for anxiety.
said, yes, reach for a Lucky instead of a sweet. That was Lasker's tagline. So when you're thinking about how you're going to cure breast cancer, and you're going to help women with breast cancer, so you've got this wonderful halo, you're operating under a halo, and then you can say, as the climate people do, well, we're not really sure. I mean, the data are not in yet, and there's some controversy. Yes, of course, but we're going to cure you. Boy, you can just keep on going down that road. Mm-hmm. And as the Arabs say, I love this Arab expression, no matter how far down the wrong road you've gone, turn back. So I think, what is the critical mass of women? What do we need to be able to turn back, despite the fact that they're steamrolling down there because they've got money on the line here? And if you can believe some people who study these things, we need 13%. If we can get 13% of the population who understand the potential impact, the importance of the breast cancer virus, both for them, and oh, by the way, this is not just a breast cancer virus. This is an all-purpose virus. Bittner discovered it as the cause of breast cancer, and so it became the breast cancer virus. Mm-hmm. But it has been found in lung cancer, endometrial cancer, non-Hodgkin's lymphoma. In the same way that HPV causes 100% of cervical cancer, HPV causes 65% of head and neck cancer. Mm-hmm. These viruses, just like these planes going into buildings, can cause all kinds of tumors, as it turns out. This breast cancer virus is not only a breast cancer virus, and it's found in seminal fluid. Mm-hmm. So as my sister said, well, if you could find that there may be a potential role for this virus in prostate cancer, they'd fund it right away.
Well, so this episode, it is partially about advocacy, and we have these huge advocacy organizations in the U.S. focused specifically on breast cancer. Are they in the boat on this at all? And if not, how do we get them involved in the conversation?
They are somewhat, insofar as some of the organizations have funded the research in very modest ways. I think that they fund it in modest ways because they may be persuaded that the data are not so strong, but they may be persuaded by their donors. Mm-hmm. Don't nail down the virus, because they go away, their donors go away. What are we going to do with the race? What are we going to do in October? Mm-hmm. I know that sounds very jaded, but it's true.
Yeah.
I think it's a factor. Mm-hmm.
So I'd invite you and Dr. Holland to come and sit at this table, and let's open up a broader discussion and shed some more light on this.
I would suggest, I would love for Dr. Holland to come, but he's 91. And he's a man who's, sort of like on the mountain. I think the viewers, if we could provide a link, the National Library of Medicine has a videotape of Holland presenting his data at this 60th anniversary celebration. Just let the people watch that. That's it. It says it all. And then make their own decision. I think the women who've had breast cancer need to know that if and when we prove that this virus causes breast cancer, you're going to want to know whether your breast cancer was caused by the virus, because you're going to get a different treatment. Right? Mm-hmm. You're going to get a different treatment. And if you don't want to get breast cancer, like you don't want to get cervical cancer, then you do have a dog in the fight. You do.
So if we assume that not many patients know about this virus, what about the medical community? What about the doctors that are treating these women? Are we getting Dr. Holland's information and research into those hands that can influence the prescribing, that can influence the treatment protocols, that can influence all of the things around that? Are we getting to that grassroots level?
Not until you get the full academic, benediction on this as the cause of breast cancer.
I will tell you that I have been walking around for a year talking about this in a lot of different environments, and specifically with the doctors with whom I'm working on patients who have breast cancer. And they all say the same thing. I say, there's a virus that causes breast cancer. They say, yeah, okay. And I say, no, really, there is. And they say, okay. And I said, do you want me to send you some information? And they're like, that's okay, that's okay. And I'm sort of fascinated that instead of having the intellectual curiosity, I'm getting a lot of whatever. There is so much, it's not even resistance, it's just disregard. It doesn't even seem like anyone's even curious.
And what if we included the other cancers that this virus is responsible for?
I think that would have an impact. It's like anything else. It's just, it's very, very interesting how I find it almost unbelievable. There are people I've known and worked with for years, and I'm like, guess what? And they're just like, that's nice, I'm gonna go have lunch now. See you next time. And I'm like, this is very interesting. It's complete, it's not even, I don't want to think about it. It's just, okay, disregard. There's a lot of disregard. And I find it kind of amazing. Maybe part of it is that it is such a huge deal and affects such a huge number of people. It can't possibly be that simple that there's just a virus. Can't possibly be that we could just cure breast cancer with a shot. How could we ever really do that? Not breast cancer. I think there's some of that. Some of it is just that can't be, and some of it is I don't know, I don't want to think about it. And we're so enmeshed in what we're in right now. But I still find it surprising that even just out of curiosity, there aren't more people who are like, oh really, just tell me more about it. I'm just curious what you're going to say. No one seems all that interested. At least that's been my experience, which I find fascinating. Every once in a while someone is interested, but it hasn't been the teams of people that I've been working with.
Holland, 3 years ago, presented his latest update on his research on the breast cancer virus to the AARC in Philadelphia in April. And he found the breast cancer virus in 94% of women with stage 4 breast cancer in their fluids, malignant pleural fluids, malignant peritoneal ascites. 94%. Why was that not front page news? Don't know. But this was the story with HPV and cervical cancer, the exact same story. Zerhausen, presented his data 30 years before we got the vaccine, and he was run out of Florida. Run out of Florida. He said, okay, I'll go back to Germany, thank you very much. And he worked in Germany. He went to the pharmaceutical companies and he said, you could make a vaccine that would prevent cervical cancer. And they said, and this is on the record, him saying this, they told him there's not enough money in it. When he was awarded the Nobel Prize, his address, Nobel laureate address, included a discussion of other viruses implicated in the cause of cancer, and the breast cancer virus was one of them that he talked about. So it's not a matter of people not knowing, it's a matter of traction.
Yeah. Well, it seems we've made a lot of progress. It seems to me like we have a lot of work to do. Communication is key, getting the word out there, and I hope that the people watching this at least have some curiosity to go to their physician and inquire about this virus and start a dialogue. So
Absolutely.
I thank both of you for joining us.
Thank you.
It's been a great series, and I invite you to come back again and keep us updated.
Absolutely.
Thank you.